Morning, all of you. So we are.
पहले बोलो सर जुड़ गए आप लोग
So have you joined, everybody? Can somebody tell if I am able, if I am audible?
Yes, you are.
Okay, fine. Okay, so we are discussing water and electrolyte disturbances. So, what is how much of the body weight is water? You know this 50 to 70% of the lean body weight is the total body water. Out of this, 2/3 is the intracellular fluid and 1/3 is the extracellular fluid. So intracellular fluid is more as compared to the extracellular fluid, and most of the extracellular fluid is extravascular interstitial fluid, and intravascular plasma volume is 1/4 1/4 of the extracellular fluid. So coming on to this question, 60 kg man, so how much intracellular fluid is going to be present and how much extracellular fluid? So intracellular fluid, how much will be present? So 70% of the lean body weight is water, 50 to 70%. So that means nearly 30 kg. So how much will be the intracellular fluid out of this? It will be 24 liters, and interstitial 14, and intravascular 1/4 of this 6. How much is the intravascular space? It constitutes, blood volume constitutes 5 to 7% of the body weight, and intracellular component again is in the form of red and white cells also, and extracellular component is in the form of plasma. 55 to 60% of the total blood volume is plasma. Now how are the intravascular and extravascular components separated? They are separated by the capillary membrane, and micropores of the capillary membrane allow only a slow escape rate of albumin, and that is returned to the circulation via the lymphatics. So a state of equilibrium is maintained. So constituting the electrolytes, how much is the electrolyte sodium, potassium, how much is there in the extracellular and intracellular fluid? The most important thing to remember is that sodium is the most abundant extracellular electrolyte, and potassium is most abundant intracellular electrolyte, and there is a lot of difference between the extracellular and the intracellular concentrations of sodium. Sodium is predominantly extracellular and potassium is predominantly intracellular. Phosphate, magnesium, both are intracellularly more important. So this again is the representation of the same thing. So in the extracellular fluid, sodium and chloride are the most important electrolytes, whereas in the intracellular fluid, it is the potassium, phosphate, magnesium, proteins, which are the more important fluids. Calcium, magnesium are nearly the same, but calcium is almost equal in both intracellular and extracellular fluid. Similarly is the case of bicarbonate. So how do you calculate osmolality? This is calculated by a usual formula: 2 into sodium plus glucose upon 18 plus urea upon 5.6, and this constitutes about 290 to 310 milliosmoles per liter. So the normal osmolality of human body is 290 to 310 milliosmoles per liter. So how is the normal fluid balance maintained? Now there is some insensible loss that occurs from the body on daily basis, constituting that stool 200 ml, sweat 500 ml is lost, and from the normal respiration, evaporation, 400 ml of water is lost. So lungs and skin loss of water occurs all the time. And how much fluid is daily taken inside? So ingested food and metabolism, 1200 ml per day is taken, and fluid intake is variable. It's nearly 500 ml per day. So obligatory urine output loss is nearly 500 to 600 ml per day. It has to be there. This much has to be there. So overall, it's the input and the output maintain a very healthy balance. So our urine output increases when there is winter season, when the fluid requirement is less, and the urine output decreases when in the summer season, when the more conservation of fluid has to be there inside the body. So a balance is maintained depending on the environment, depending on the losses, and depending on the um, uh, conditions like diarrhea, where the stool volume increases, or conditions like season, like in summers the sweating is more, so one tends to take more of fluid. So overall the fluid balance is maintained. Nearly input is equal to output. So talking about electrolytes, normal requirement of NaCl is 8 to 10 grams per day, out of which sodium of 4.5 gram intake is the normal requirement of the body. Normal requirement of potassium is nearly 1 milliequivalents per kg per day. Please remember, 1 milliequivalents per kg per day is the normal requirement of potassium. So how does the regulation of fluid occurs? It occurs through two mechanisms. One is the renin-angiotensin-aldosterone system, the atrial natriuretic peptide, and renal sympathetic nerves. So what happens is ADH is the primary hormone which causes increased water intake, and so pituitary senses that the concentration of water is decreasing, concentration of sodium chloride is decreasing. So based on that, there will be decreased or increased thirst. There will be increased or decreased water loss from the kidney. So ADH acts at the level of collecting tubule to cause absorption of water. Similarly, by renin-angiotensin-aldosterone system, there will be sodium absorption from the thick ascending limb of loop of Henle. So based on this requirement of the body, ADH has a huge potential. It can increase the osmolality of the urine up to 1200 milliosmoles, and it can decrease it up to 50 milliosmoles per kg depending on the requirements of the body. ADH is a very potent hormone which causes water absorption. Aldosterone is a very potent hormone which causes sodium absorption depending on the requirements of the body. Now, cells contain large anions, protein and glycogen. They cannot escape. So, to maintain that electrical neutrality, they tend to draw potassium ions. This is also called as Gibbs-Donnan equilibrium. So, normal kidney can concentrate urea in the urine up to 100 folds. So, as we just discussed, the urine volume decreases to compensate for the dehydration. If hydration is decreased, the urine volume decreases. So if we take more of fluid by intake of water, then that will cause ADH secretion to fall, causes ADH secretion to fall and produce a dilute urine. Now, age and diseases can impair this renal concentration ability, so that for the same amount of waste that has to be excreted, larger volume of urine is then required. And hence, if it is not happening, then the renal functions start worsening in the old age. Also, if protein catabolism increases due to high protein intake or increased catabolism, again a larger volume of urine is needed to clear the resulting increase. So if too much of proteinaceous diet is there, then large volume of urine is needed. So it is important that renal conditions are taken under consideration when prescribing the protein diet. So if renal patients are taking high protein diet that can that may not be able to get excreted, and it may further worsen the urea, uh, further worsen the renal functions. So age, underlying diseases, protein catabolism, intake of fluids, seasonal dehydration. So these are the factors which impair or affect the urine concentration ability. Similarly, response to injury, stress, and sepsis. So initially, it results in the increase in the size of the pores in the capillary membrane, and the transcapillary escape rate of albumin increases. So there is escape of albumin also from the intravascular compartment. So intravascular compartment shrinks. So there is intravascular hypovolemia and edema. Both the things occur when this happens. So what happens in response to injury? First is the shock phase. It is brief, flow or catabolic phase. And as inflammation subsides, anabolic phase, rehabilitation. This is just to tell you that fluid requirements may change in different phases of injury. So coming to the important thing, volume depletion. So a decrease in the ECF volume caused by a net decrease in the total body sodium content. Losses of sodium always combined with water losses. End result of sodium depletion is ECF volume depletion. So basically, how does volume depletion occurs? So when there is a decrease in the sodium content. So someone is having dehydration, someone is sweating, someone is having vomiting, diarrhea. So these things can cause volume depletion. And when sodium is depleted, then water is always lost with it, because the ability to hold the water in the vascular, in the interstitium, in the extravascular space is because of the sodium. So if sodium is lost, then water loss is obligatory. Sometimes this water loss can occur without sodium loss also, less of sodium loss, but most of the times it is the sodium loss which leads to the water loss and depletion of extracellular fluid volume. So what are the causes of losses, volume depletion? So it can be renal or extrarenal. GI losses leads to vomiting, diarrhea, due to vomiting, diarrhea, gastric aspiration, peritonitis, loss from the skin like excessive sweating and burns. Then renal losses because of excessive use of diuretics, osmotic diuretics, renal diseases are the causes of renal losses. So we need to remember, why is the patient depleted? So first we need to find out whether it is because of the kidney causes or the extrarenal causes. So just to have an idea how much fluid is present in the various fluids. So how much electrolytes? So saliva contains 2 to 21 milliequivalents per liter and 10 to 36 milliequivalents per liter. Diarrhea contains sodium of 40 milliequivalents per liter, and there is high bicarbonate loss in diarrhea. Jejunal, ileal, and biliary fluids have isotonic fluid loss. And gastric fluid also has sodium 40 milliequivalents per liter and potassium of 10 to 30 milliequivalents per liter. So basically gastric, sweat, saliva, diarrheal fluids, they are hypotonic fluids. And isotonic fluids are biliary, jejunal, ileal, and secretory diarrhea fluids. These are all isotonic fluids. So when hypotonic fluids are lost from the body, that means the body is losing more water as compared to sodium. So that is going to lead to dehydration with hypernatremia. Whereas if there is isotonic fluid loss, it's more of dehydration, and electrolyte imbalance either may not occur, or it will be more of will be hyponatremia or normonatremia. So what are the features of volume depletion? First, dry skin and mucous membrane. There will be tachycardia, there will be hypotension, there will be decreased perfusion of blood into the brain, so that will cause altered mental status. In the kidney, it will cause urine output, fall down of the urine output, or it may cause changes in the sodium concentration. In case of volume depletion, severe volume depletion, even blood urea and renal functions may deteriorate. And in renal causes, the urinary sodium is high, whereas the extrarenal causes, urinary sodium is less than 10 milliequivalents per liter. So it is basically the urinary sodium which is required when we are not able to find out the cause of volume depletion, whether it is renal or extrarenal. Mostly it is very clear from the history, because if someone has diarrhea, vomiting, he'll be able to tell that he has these complaints. But sometimes when patient is seemingly depleted and he doesn't have any such history, we need to find out whether it is the renal cause or the extrarenal cause. So urinary sodium more than 20 milliequivalents per liter will suggest the renal cause. So in case of volume depletion, in mild to moderate dehydration, increased oral intake of sodium and water. Now, severe volume depletion is said to occur when the patient is not able to take orally, is hypotensive, is in tachycardia, is in shock. So in that situation, he will not be able to take orally, and oral absorption may be poor in that situation. So in that situation, we need to give IV replacement of normal saline. So basically, IV normal saline is indicated in cases of severe volume depletion. Severe is said when it is hemodynamic compromise, whereas in mild to moderate, generally its oral will suffice. So what fluids are given? Different fluids are ECF, Ringer's lactate, sodium chloride, half sodium chloride, 0.5%, 5% dextrose, 3% NaCl, then some colloidal fluids like albumin and hexastarch. So basically what we need to remember is the sodium concentration. Ringer's lactate contains a little less sodium concentration, but overall the osmolality is nearly as compared to the extracellular fluid. It's almost isotonic. 0.9% NaCl, which is most commonly used, it is 154 milliequivalents of sodium, and it is slightly higher osmolality as compared to the extracellular fluid, or higher range of the normal. So this is in the lower range of normal, this is in the higher range of normal. 0.45% NaCl is half of that of sodium chloride, and it is having lower osmolarity definitely as compared to ECF. So what we need to remember is when someone is having a loss of different kind of electrolytes like potassium, bicarbonate, calcium, then Ringer's lactate will be the fluid of choice. But if it is primarily because we want to maintain hemodynamic stability, we want to avoid any kind of hemodynamic compromise, then we need to give sodium and chloride, which are the chief electrolytes in the extracellular fluid and which maintain the body fluid. So in case of diarrhea, in case of vomitings, maybe RL may be preferred, Ringer's lactate. But in case of hypotension due to general causes, like because of sepsis or because of any kind of depletion of dehydration, so in that situation it may be because of NS normal saline, which will be the fluid of choice. Similarly, 0.45% NaCl will be used. D5 will be used in cases of hypernatremia, when the sodium concentration is already high. We don't want to give more of sodium, but at the same time we want to correct the fluid balance. Similarly, 3% NaCl will be fluid of choice in the hyponatremia. So 3% NaCl for hyponatremia, D5 and 0.45% NaCl for hypernatremia, NaCl for maintaining blood pressure or to maintain in hemodynamic stability, and bring us lactate for major electrolyte losses like diarrhea and vomiting in that situation. So this is the major fluid of choice that way. So we give someone 1 liter of 5% dextrose. Where does it go? 65% in the intracellular fluid, 27% in the interstitial fluid, and 8% in the plasma. Sodium NS will go into the plasma and interstitial fluid. So this is what the difference we wanted to highlight. So 5% dextrose will take care of the intracellular dehydration also, whereas NS, normal saline, will take care of the maintenance of plasma interstitial fluid volume. If we give packed red blood cells, it will go only to the plasma. So we'll have, so depending on the cause where the fluid depletion has occurred, we can choose the fluid. If it's only the blood that has lost, then we give only blood. If it is the interstitial, interstitial fluid that has lost, then we give normal saline. Whereas if it is intracellular dehydration that has occurred and which has caused hypernatremia, we give 5% dextrose. So coming on to some other definitions, when do we say oliguria has occurred? When the output of urine is less than 400 ml. When do we say anuria? When it is less than 100 ml. And when do we say polyuria? When the output is more than 3 liters per day. Minimum urinary osmolality is 50 milliosmoles per kg and the maximum is 1200 milliosmoles per kg. That is maintained by the ADH hormone. And the minimum obligatory urine output has to be 500 ml to maintain this osmolarity. And maximum urine output has to be 12 liters to compensate for all the losses. So if it is above or below that, definitely there is some kind of pathology. So there are certain hypervolemic states, but the effective volume is less. These are the fluid overload states: congestive heart failure, nephrotic syndrome, CLD, hypoalbuminemia. These are hypervolemic states, but the effective blood volume is less because it's more of extravasation into the interstitium. So how do we manage fluid? Initial aggressive therapy of 20 to 30 ml per kg per hour is given. This is for initial aggressive therapy. Till when is this given? Till the blood pressure is maintained and output is 0.5 to 1 ml per kg per hour. If someone is 50 kg person, so 50 ml per hour of urine output if it's happening, then and the blood pressure, systolic blood pressure is above 90 millimeters of mercury, till then we give 20 to 30 ml per kg per hour. After that, it depends on the urine output and patient status, maintenance fluid. This is a general formula which we use for calculation, but it is more of the urine output and patient status. We generally give nearly 500 ml to 1000 ml more than the urine output, counting for the other insensible losses like stool, sweating, respiration. So these things comprise of 1500 ml to 1000 ml above the urine output. For example, if someone has passed nearly 1 liter of urine in a day, so the next day we give 2 liters of fluid so that we count for the insensible losses. And what are the electrolyte requirements? 1 to 2 ml millimoles per kg per day. Potassium 0.5 to 1 millimoles per kg per day. Important thing is that in certain fluid overload states, though the intravascular volume will be depleted, patient may be a little on the lower high blood pressure side, but at the same time we need to keep in mind that the fluid overload states tend to cause pulmonary edema and edema. anasarca. So we should avoid fluid overload in those states and treat the underlying pathology completely first. So talking about a few electrolytes. So hypokalemia is the intracellular depletion. So potassium will be depleted. When we say hypokalemia, it will be the depletion from the extracellular compartment. So it's less than 3.5 milliequivalents per liter. So how does that depletion occurs? So either it can occur by gastrointestinal causes or renal causes. In the gastrointestinal causes, it's caused by the reduced intake of potassium or increased loss from the GI tract, like vomiting, diarrhea, nasogastric suction. One important thing is the intracellular shift of potassium. Now, we just saw a few minutes back that potassium is mostly an intracellular fluid, intracellular electrolyte. So to maintain that, there are a lot of intracellular shifts that occur. Potassium tends to shift more to the intracellular side. So that causes further depletion in the extracellular potassium. But that is detrimental. Potassium, whatever is, even if it's less, but less potassium is also crucial. So in situations like periodic paralysis, alkalosis, administration of insulin, stimulation of beta-2 receptors with the epinephrine and salbutamol, these situations will cause shifting of potassium from the extracellular to the intracellular compartment. In the renal causes, if we use more of diuretics or osmotic diuretics, metabolic alkalosis, hypermineralocorticoidism, in renal tubular diseases, these situations will tend to cause more of sodium absorption and more of potassium excretion into the urine. So that will cause hypokalemia. Then basically it's magnesium depletion and hypocalcemia, which are the miscellaneous causes of potassium depletion also. So what are the problems that can occur with hypokalemia? Hypokalemia can cause arrhythmias, conduction defects. It can cause fatigue, paralysis, rhabdomyolysis. It can cause paralytic ileus. It can cause nephrogenic diabetes insipidus, metabolic alkalosis. The most life-threatening causes effects are arrhythmias. The ventricular tachycardia, ventricular fibrillation can occur with hypokalemia. It's very dangerous. And sometimes patients come to us with weakness of all the four limbs. That is because of hypokalemia. Then paralytic ileus can occur. Patients can have presentation like intestinal obstruction, and patients can have features of nephrogenic diabetes insipidus. All this can happen with hypokalemia. So there are certain ECG changes of hypokalemia: increased P wave amplitude, reduction in T wave amplitude. So P wave decreases and P wave increases. P wave is slightly higher and T wave decreases. U waves become prominent. So U waves which are prominent after the T waves is called U wave, and this is seen in hypokalemia. So U waves become more prominent. So how to treat? So potassium is mild, moderate, and severe. 3 to 3.5 is mild, less than 2.5, from 3 to 2.5 is moderate, and less than 2.5 is considered to be severe. Generally, with less than 2.5, there will be manifestations of severe hypokalemia. So it's important that we treat at this stage only, so that this stage doesn't land up. Because if this happens, then we have very less time for improvement. So we have to give IV potassium. But IV potassium doesn't mean fast. IV potassium has to be given slowly in infusion with certain principles in mind. With mild and moderate, we can give oral potassium supplementation. So principles of IV therapy. So concentration in IV fluid should be less than 40 milliequivalents per liter, and rate of infusion of potassium should be less than 20 milliequivalents per hour in peripheral vein. Basically, important thing is we don't give it fast. We give it only at the rate of 20 milliequivalents per hour. And it has to be repeatedly assessed because even hyperkalemia is dangerous. So hyperkalemia can occur primarily because of the renal failure. It is because of the inability to cause excretion of potassium that causes hyperkalemia. Now, sometimes potassium may be shifted from intracellular to the extracellular fluid in the opposite causes. So in alkalosis, we had the shifting from outside to inside. Now here in acidosis, it is from inside to outside. So use of certain drugs, adrenal insufficiency and renal failure are prominent causes. So generally hyperkalemia doesn't have much of the causes, but still it is even more dangerous. It can also cause ventricular arrhythmias, ventricular fibrillation, sudden cardiac arrest can occur because of hyperkalemia. Tall T waves is the most prominent ECG sign in a case of hyperkalemia. So in hypokalemia, we had decreased T waves. In hyperkalemia, we have tall T waves. At the same time, we had U waves prominent in uh, hypokalemia, but here we don't have any specific U wave. The treatment consists of certain drugs like calcium gluconate, insulin with dextrose, beta-2 agonist, bicarbonate, potassium binders, diuretics, hemodialysis. The principle of these therapies is that it will cause intracellular shift of potassium. So excess of fluid in potassium in the extracellular fluid will go into the intracellular compartment. And calcium gluconate is the primary treatment which is given to stabilize the cardiac memory. Talking about hyponatremia. So when the sodium concentration goes below 135 milliequivalents per liter, we say hyponatremia. So some causes of uh, hyperosmolar hyponatremia are hyperglycemia and mannitol. So basically that will cause decrease in the serum sodium by 1.7 milliequivalents per liter, every 100 milligram increase in the sugar. Now, total body sodium content is reflected by the ECF volume. So basically, when we talk of hyponatremia, we talk of three things: whether it is hypovolemic hyponatremia, whether it is euvolemic hyponatremia, or whether it is hypervolemic hyponatremia. So, for euvolemic hyponatremia, the causes include hypothyroidism, SIADH, certain drugs, and adrenal insufficiency. SIADH, which is syndrome of inappropriate ADH secretion, means increased ADH secretion in response to body insults. Hypothyroidism and certain drugs. Hypervolemic will occur because of hypervolemic states like in CHF, cirrhosis, renal failure, or we can also say it as dilutional hyponatremia. Now, how to differentiate? If the urine sodium is more than 20 milliequivalents per liter, it will be due to renal failure. Whereas if the urinary sodium is low, then that is supposed to be because of the other causes of hypervolemic hyponatremia. What about hypovolemic hyponatremia? Hyponatremia, which is because of the renal, extrarenal, again can be differentiated in this way. And in extrarenal losses, it will be mostly because of vomiting and diarrhea and burns. So in hyponatremia, it is important to identify whether symptoms are present. What are the symptoms of hyponatremia? It is the CNS symptom. Remember, for potassium, we had uh, cardiac symptoms, the arrhythmias, the motility of the bowel. In hyponatremia, it is the CNS symptom. Next feature has come. So important thing is that sodium has to be corrected slowly. We have to correct it at not more than 6 to 8 milliequivalents per liter over 24 hours. So if we correct it fast, what can occur? There can be pontine myelinolysis, increased risk of central pontine myelinolysis if the sodium correction is faster than it is recommended. So whether immediate treatment is required, it depends on the CNS symptoms. If CNS symptoms are present, like confusion, altered sensorium, seizures, then in that situations, the urgent treatment is needed. Okay, so what are the choice of fluids? Now, 3% NaCl contains 513 milliequivalents per liter of sodium, whereas 0.9% NaCl will contain 154 milliequivalents of sodium. So depending on, there is a formula, infusate sodium minus serum sodium upon total body water plus 1. So if infusate sodium, suppose we are planning to give 3% NaCl, it will be 513. Serum sodium, the value of the patient, total body water based on the weight plus 1. So that will tell us how much change in serum sodium will occur with 1 liter of any particular fluid. So when do we prefer 3% NaCl, 3% solution? So when sodium levels are very low, less than 120, patient is symptomatic for central symptoms like seizures, altered sensorium, and what is the maximum infusion rate is 1 cc per kg per hour. So hypernatremia, what is hypernatremia? It is the elevation in the plasma sodium concentration above 145 milliequivalents per liter. So it's basically because of ECF volume depletion. So volume depletion causing a relatively increased sodium level is the major cause of hypernatremia. Again, it occurs because of dehydration. Only dehydration is the most important cause. And it occurs mostly in those patients who are elderly, who are not physically handicapped, who are not able to take care of themselves, and their decreased oral intake is there. In that situation, it's not the volume loss from the body that is responsible for fluid depletion, dehydration. It is because of the decreased intake of the fluids. Not to respond to the thirst adequately is the reason for hypernatremia. So in this, the treatment is primarily fluid. So this is all about the fluid and the major electrolytes, sodium and potassium, which are important in the wards. So if anybody has any questions, he or she may ask. Okay, thank you then.
Yes. Right.
तो क्वेश्चन को नहीं आया
यूट्यूब पे कोई नहीं डाला नहीं कुछ नहीं है up and down. Frequency. कौन सा
Drugs. हटा दिया वो?
हाँ हाँ डॉक्टर कैन यू ऑडिबल टू
Good morning, everyone. In last class, we have covered drugs acting on the uterus, but they were hormonal agents and they acted primarily on the endometrium. And we have seen that how they change the functions of the endometrium, the secretory activity of the endometrium changes under the influence of various hormones, which are either secreted from the gonads and or functions like ovulation, which are determined by the gonadotropins. Now, in continuation to that, we will be covering today other set of drugs which act on the uterus and they affect the contractile properties of the smooth muscles. So it is myometrium. The drugs which were earlier discussed were primarily changing the characteristic features of the cells and secretions of the uterine endometrium. And today, the drugs that will be covered will be primarily affecting the myometrium. And their uses will be discussed. What would be the uses of these drugs? And you will definitely find that there is distinction when we talk about drugs which were covered earlier and drugs which will be covered in this class. Now, this is what we had already done: uterine endometrium and hormones, how they alter and how they affect different changes in the endometrium. And these are the hormones, how they change. This is getting the peak of these hormones, which coincides with ovulation. Now, when we talk about drugs which act on the myometrium, these are drugs which either stimulate the uterine smooth muscles. So these are uterine smooth muscles, uterine smooth muscle contractile agents, and then you have agents which bring about relaxation of the uterine smooth muscles. Now, when we talk about these drugs, I think this hormone, again, oxytocin, has already been covered by you. So these drugs act like oxytocin. So they stimulate the uterine contractions and are called as oxytocics, ecbolics, or abortifacients because they increase the contractile activity of the uterine smooth muscles. Now, when we look at these hormones, we are all familiar with the hormone which is endogenously released from the posterior pituitary, which is oxytocin, which is present there in association with vasopressin. So I think the functions of these two hormones are not new to you. You have already covered. And the second set of drugs which will be covered is drugs which are derived from ergot alkaloids. These are ergometrin and methyl ergometrin. And then again, another set of agents, again, not so new to you. You have already read about prostaglandins. So prostaglandins like PGE2, PGF2 alpha, methyl prostaglandin F2 alpha, or misoprostol, which is an analog of PGE2. All these bring about contractions of the uterine smooth muscles, but there are some characteristic differences among these agents, which we will be covering, and thereby, you see, all cannot be used for every purpose to induce uterine contraction. Now, when we talk about oxytocin, you know this is a naturally synthesized hormone, synthesized primarily in the hypothalamus, that is paraventricular and supraoptic nuclei. It is a peptide hormone secreted from the posterior pituitary, and I think you all are aware of its function. When we talk about its physiological role, it has its action primarily in the uterus or in the breast. So it increases the frequency and force of uterine contractions, and such an effect is required at the time of labor when the gestation has completed and uterine contractions are inherently induced by the release of the hormone in the body from the pituitary gland, posterior pituitary. And what is so different about the action of oxytocin on these uterine smooth muscles? So when we look at the contractions brought about by oxytocin, there is very characteristic feature of these contractile effects which are seen on the uterine smooth muscles. You will see there is increase in the force of contraction when we talk about uterine contractions at the end of gestation. So they increase the force of contraction, but there is intermittent phase where there is no contraction. So you have a wave of contractions coming in a pregnant uterus at the term, and then it is followed by a gap, and then there is another, like it is in a form of pulses, like it comes like a wave of contractions followed by a gap. That gaps allows for I think does not harm the fetus because of forceful contractions. And when we look at the contractile activity of uterine smooth muscles, you see the sensitivity of the uterus increases to oxytocin as the gestation advances. So it is known that estrogens, they sensitize the uterus for the action of oxytocin. So the uterus has already been acted upon by various hormones during the gestation, and all steroid hormones are produced by the placenta as well. So there is abundance of these hormones, and they alter the responsiveness of the uterine smooth muscle to the oxytocin, and this sensitivity is very high towards the end of the gestation. So there is increase in the sensitivity in third semester, and from third semester onwards to the oxytocin. The contractions of the myoepithelial cells surrounding the alveolar channels is also enhanced, and action of oxytocin brings about milk ejection also. Now, what is the mechanism of action of oxytocin? Oxytocin acts through oxytocin receptors. As I said just now, that the sensitivity of this oxytocin receptor to oxytocin increases when these sites have been, when the uterus has been acted upon by estrogens. So these are G protein coupled receptors. It is seen that there is depolarization of the muscle fibers. There is influx of calcium ions. There is inositol triphosphate mediated intracellular calcium release. And it is also seen that there is increase in the oxytocin receptor number in the later part of pregnancy. So you see the sensitivity increases because of increase in the number of oxytocin receptors. And then oxytocin also is known to increase prostaglandin synthesis, and that is also adding to the action and brings about contractions. So it is released at the site released by the endometrium, prostaglandins, by the action of oxytocin. Now, if we know that, when we know that oxytocin is a peptide hormone, so it is quite clear that it cannot be administered orally and it needs to be administered intravenously. It is given in the form of doses which are depicted as units. So 1 milliunit per minute is the rate at which it is administered and may be increased to 5 to 20 milliunits per minute. But what is important that when oxytocin is used for inducing uterine contraction, one has to do monitoring both of the mother as well as for the fetus, monitoring of the fetus. There should not be any discomfort to the mother as well as the fetus, because at times the contractions are so forceful, but they affect the fetus as well. So, and if you look at the use of this oxytocin, this can be used as nasal spray 2 to 3 minutes before nursing. So because it facilitates milk ejection, so this can be used for this purpose also. And then it is inactive because orally it is inactive because it is degraded, being peptide in nature. It has a short t-half of 5 minutes. So it is to be administered intravenously. Its effect or action is to be monitored constantly. You have various preparations available. You have pitocin, syntocinon, to name just few. And you have parenteral preparations available as 10 units per ml for injection, and nasal, the 40 units per ml spray. So when it is to be given parenterally, it is added to the IV saline, and then slowly its rate can be controlled and monitoring can be done. Now, what are the uses of oxytocin? When we know that its effect is primarily seen on the uterine smooth muscles and it brings about contractions, find its use for the induction of labor. So when the labor does not occur on its own and it needs to be assisted or needs to be induced, and with the help of hormones or other agents, oxytocin is the agent which is preferred for this effect and is given intravenously 10 milliunits, 10 milli-international units per minute, or 2 to 4 international units can be given. One has to monitor and see the effect to induce labor. It can also be used when the uterus is not responsive and there is uterine inertia. It doesn't produce contractions on its own, and it is required that the uterine contractions are to be induced by some agent. It is used to control postpartum uterine hemorrhage because it brings about contractions and thereby decreases the hemorrhage as well. It is also used to expel out retained placenta if it is not expelled out on its own. It can also be used for milk ejection, for which you have nasal preparations available. Now, the drug is again, though it is effective, quite effective in inducing uterine contractions, but it may produce certain adverse effects for which I think it is important to monitor the patient. It may produce soft tissue injury because the forceful contractions that it produces may produce injury both to the mother or to the fetus. So soft tissue injury primarily in the mother, I think one has to be very careful and monitor and accordingly adjust the doses or take other alternative measures so that this can be minimized. It may produce uterine rupture if the contractions are too forceful. It may produce water intoxication because it is released from the posterior pituitary and where it is stored along with vasopressin. So some of the properties like vasopressin may be seen with oxytocin as well. So water intoxication may occur. So one has to be careful in patients where blood pressure is already high, and that kind of monitoring is required for these patients. So if water intoxication is already there, there is too much of high blood pressure. So one may use for other agents instead of using oxytocin. And if there is fetal asphyxia, that may also be seen with the use of oxytocin. So all these effects, they require complete monitoring when the drug is used for producing its therapeutic effect or benefit in patients. Now, it is contraindicated if there is fetal distress, if there is premature fetus, or if there is abnormal fetal presentation. So, since the contractions are too forceful, its use is contraindicated in these conditions. Now, besides oxytocin, you have other agents which bring about contraction of the uterine smooth muscles, and these agents are derived from the ergot alkaloids. They are alkaloids of different classes. You need not remember all these classes. The ones which are effective on uterine smooth muscles are highlighted in blue color. So ergotamine, dihydroergotamine, or ergometrine, also called as ergonovin. These are the alkaloids which are effective on the uterine smooth muscle and bring about contractions. And other alkaloids, other agents you are all familiar with are bromocriptine and methysergide, which are derived from the ergot. Now, when we look at the properties of these alkaloids, you see you have different agents: ergotamine, ergotoxin, ergonovin. So here these are the principal alkaloids which are there. In this group, you have ergotamine, ergosine. Here you have ergocristin, ergocryptine, ergocornin, and among this you have this ergonovin. What is the use of these agents? When we look at their relative activity, it is known that these group of agents or alkaloids, they primarily produce vasoconstrictor effect followed by oxytocic effect and then alpha blocking effect, and thereby you see their use is advisable or advocated in migraine. Second set of alkaloids primarily produce alpha blocking effect followed by vasoconstrictor effect, and they are least effective as oxytocic agents, and they may be used in various vascular conditions, vascular diseases. And the last one, that is ergonovin, is primarily producing oxytocic effect followed by vasoconstrictor effect and alpha blocking effect, and is used to control postpartum hemorrhage. So this is the agent, this is the group or the agent which is used for its effect on the uterine smooth muscle. Now, how does it bring about contractions, and what is the characteristic difference between the contractions produced by ergot alkaloids and oxytocin? You see, these ergot alkaloids, they also increase the force and frequency of contractions, but there is a difference. At low doses, you will find that these contractions are phasic contractions. So as there is slight increase in the dose, you see there is increase in the basal tone and contracture. So these contractions persist continuously, unlike oxytocin, where you see intermittent contractions and there is a phase where there is no contraction. So this is the characteristic difference between these agents. So maybe small doses produce phasic contractions, but when there is small change, small increase, and it's difficult to then decide about the doses used and the effect that is seen. So this, as a result of these persistent contractions, this is not the preferred agent for induction of labor. And it is also seen that lower segment of the uterus also contracts. So unlike oxytocin, where lower segment and cervix relaxes and allows the exit of the fetus, when the uterine smooth muscles are contracting, the cervix relaxes so that the fetus can be expelled out or can be can exit from the uterus. Whereas with the action of ergometrin, you see the not only the contractions are forceful, but the lower segment is also contracting. So this is not the required feature or required effect of drugs on the uterus for the purpose of induction of labor. So it is likely to cause damage. When the lower segment is contracted and there is forceful contraction, it is more likely to cause damage than producing any beneficial effect. So thereby, this group of drugs or agents are used to control postpartum hemorrhage. These are also used to bring about involution of the uterus after the labor has taken place, because the uterus enlarges in size and it must revert back. So agents like ergometrin can be used to bring about involution. If there is incomplete abortion, these agents can be used to expel out the contents by inducing the contractions. And the preparations which are available are ergometrin, methyl ergometrin, oxytocin plus ergometrin. So I think depending upon the use and need, these preparations can be utilized. And it again produces certain adverse effects like nausea, vomiting, rise in blood pressure. There may be decrease in milk secretion. These agents are again contraindicated if there is vascular disease, hypertension, toxemia, liver and kidney disease, during pregnancy, and these are also contraindicated in third stage of labor. So they are not to be used for induction of labor as such. Now, another set of agents which are available, which bring about contractions of the uterine smooth muscles and act like oxytocin. These are prostaglandins and their analogs. You have prostaglandin E2, prostaglandin F2 alpha, with 15-methyl prostaglandin F2 alpha. So these agents have effects similar to that of oxytocin. So these agents or prostaglandins, they promote uterine contractions and can be used to terminate pregnancy at any stage. So as you see with oxytocin, the sensitivity to oxytocin increases as the gestation advances because of increasing the number of oxytocin receptor and because of increasing the sensitivity to the oxytocin. Unlike that, you see, prostaglandins can bring about contractions at any stage of the gestation and to terminate pregnancy at any stage. They can be used to induce abortion only when it is advisable because of some medical reason. It can be used in first and second trimester to bring about contractions and abortion. They can also be used for priming and ripening of the cervix. So they can be applied even locally to bring about cervical ripening or cervical relaxation. You have various gels and vaginal tablets available which can be locally applied. You have drinoprostone, vaginal gel, vaginal tablet, or vaginal suppositories are also available. You have agents like mifepristone and misoprostol, a combination that can be used for early abortion. One prostaglandin and one antiprogestin can be used to induce abortion. Then you have denoprost and carbaprost, which are again agents which bring about contractions and can be used to induce abortion. So first effect, we have seen that they can induce abortion. They can also be used to induce and augment labor. So if labor is delayed, is very slow process and is a kind of a state where you see that it is a kind of non-responsive state and it needs to be facilitated, or inducing agent is to be administered. And if oxytocin can also be not used, cannot be used for medical reasons, then prostaglandins can be used, because the water retention effect of oxytocin that is seen is not seen with this group of agents. So they can be used for induction and augmentation of labor. They can be used to induce cervical priming. They can also be used to control postpartum hemorrhage. So these agents may also produce side effects which are not very serious, but they may produce nausea, vomiting, may produce diarrhea in some users, and may produce fever. Now, what are the advantages? So these agents, there is no antidiuretic effect. So it does not produce ADH like or vasopressin like effect. Thereby, they are superior to oxytocin in preeclampsia and in cardiac and renal diseases as well. So patients where you see there is an increase in blood pressure and there is altered kidney functions as well, you can avoid using oxytocin and prostaglandins can be used instead. Now there is another set of drugs which are effective on the uterus, but they bring about relaxant effect on the uterine smooth muscles. And you see these agents are called as uterine relaxants or cocolytic agents. Now, what are the uses of these agents? These agents, they delay or postpone labor when it is not advisable to induce labor, maybe because of reasons that fetus is not yet mature enough to be delivered, and some more time is required. It can be delayed or postponed by using some relaxant agent. Also, in certain cases where uterine contractions or the sensitivity to the uterine smooth muscle is high to this stimulant effect, and that may result in abortion. So relaxants can be given to arrest these contractions and to arrest threatened abortion as well. Because of uterine contractions, some may experience dysmenorrhea, and these agents can be of help in these individuals as well. So these agents, they bring about relaxant effect on the uterine smooth muscles. The drugs that are effective on uterine smooth muscles for this effect are drugs acting on the adrenergic receptors as agonists like ritodrine, terbutaline, or isosuprene. These are the agents which can be given either intravenously or then subsequently can be given by intramuscular or by oral administration. And one may advise complete rest to the individual along with the use of these agents. Now, besides using drugs acting as adrenergic agonists, there are other agents which also bring about uterine relaxant effect. You have magnesium sulfate, which has been used earlier, can be given intravenously, followed by at a dose of 2 to 4 grams over 10 to 20 minutes, followed by 1 to 2 grams per hour. So it brings about relaxant effect. Drugs like calcium channel blockers like nifedipine can also bring about relaxant effect on the uterine smooth muscle. Then you have prostaglandin synthesis inhibitors like aspirin, ibuprofen, indomethacin. They also produce relaxant effect because they inhibit the synthesis of prostaglandins. Although it is not advisable to use so many drugs when during pregnancy, but I think the decision is to be taken regarding the adverse effects of these drugs, whether these are to be given or not to be given, or what agent is to be given to the user of or the in an individual where relaxant effect is required. Then progesterone can also be used in certain cases because it is known to decrease the sensitivity of the uterus to the oxytocin. So a kind of a relaxed effect which may be beneficial for individuals. The chances or risk of threatened abortion is very high. So one may have to use some of the agents which are mentioned above. Primarily, especially the drugs which are adrenergic agonists are in use. Then you have newer agents which are active or effective against oxytocin receptor and the action produced by the oxytocin through receptors, that is oxytocin antagonist etosiban. Now, etosiban is the agent which was first used and shown efficacy in conditions where relaxant effect is required. Thereafter, number of other agents also have been made available, that is nolasiban, varosiban, and retosiban. So the etosiban is one agent which has been well studied and is shown beneficial effect. It is given intravenously, 300 microgram per minute. It is shown to be as effective as beta agonist as far as uterine relaxant effect is concerned. It is suitable alternative to beta agonist because it is not it has not been shown to produce side effects like other beta agonists or drugs acting on beta receptors they produce. So this is considered to be a safer drug and is the effective agent or as a uterine relaxant. As far as uterine relaxant effect is concerned, it has been shown to be effective as an implant agent, effective against implantation failure and in preterm labor. So this brings up, because it acts by bringing up relaxant effect on the uterine smooth muscles. It may produce nausea, vomiting, and headache in the users, but overall this drug is as effective, and when it is not producing any side effects, I think this is likely to be the agent which will be used. I think with this we broadly cover drugs which are effective on uterine smooth muscles. You can mark your attendance if just give me 1 or 2